Thank you, Dr. Desai. So we'll now move on to the discussion session. If you have questions, please feel free to type those in the chat, and I will be asking those questions to our panel. So let me introduce our panel once again. We have Dr. Alice Fan, we have Dr. Arpita Desai from UCSF, we have Dr. Suchi Gulati from Cincinnati, and we have Dr. Tony Chueri from Dana-Farber. So while we're waiting for our participants to type in questions, I guess I have one question for Dr. Fan. So you mentioned something about 3 to 5% of patients yeah, have some genetic mutations in patients with renal cell carcinoma. What is your approach, Dr. Fan, in terms of testing these patients? Do you go use like multi-gene panels and test for, all of the genes that you talked about, or should the testing be more specific based on the histology?
That's a great question. So for the patients where they're age 46 or younger, I send them for formal genetic counseling and testing. So I send them to our genetics team where they'll do their germline panel that includes the RCC genes. For a patient where for example, we're suspecting FH loss, fumarate hydratase loss in HLRCC, I'll send them both for genetic testing, with the genetics counselors and teams, but I also send the tumor for molecular testing. And I like the targeted panels that include a large number. Our pathologists will also routinely run fumarate hydratase immunohistochemistry. So that can be kind of the quickest look to see whether or not the protein's there. But the protein level, the IHC, is not 100%. So we definitely want to back that up with genetic testing, genomic testing.
Gotcha. Okay. So while we're waiting for the questions to come in, our intern, BTF intern, Vidi, will do a Zoom poll. So I would ask everybody to participate in this. Vidi, you can go ahead and start the poll, and then we will go back to discussions again after that.
Hi everyone, my name is Vidi. I'm one of the interns at Binaytara Foundation. So Dr. Fan and Dr. Desai wrote 2 questions each just to kind of bring everyone back together on what we just discussed. So I'm going to be displaying them on your screens, and then the Zoom poll will just show up on the Zoom interface, and then just feel free to participate from there. All right, can everyone see these on their screen? It should say question 1 at the top.
Yep.
Awesome. And then Sam will go ahead and start launching the polls.
As a hint, I said it the most times.
And Dr. Fan, if you want to add any further explanations or address anything else you want to say to these questions, feel free to add that as well during the explanation.
Sure. So von Hippel-Lindau tumor suppressor is definitely kind of the driving event in greater than 90% of clear cell. So it's the most common in the most common RCC subtype. And I see that MET and PTEN came up as well. And I definitely mentioned those. MET is more commonly in papillary renal cell carcinoma. And PTEN is less common, but it can happen in a number of them. But definitely the one to remember is VHL and clear cell.
Looks like there's a little copying and pasting error on our end over here.
I hope everybody gets it right.
All right, in case you didn't, you'll have to think about this one.
Oh, wait, so then though, that actually changed the answers. Okay, so.
Yeah, just use what's on the Zoom poll itself to submit your answer, and then we'll have the explanation on the next slide.
So I apologize. I think I submitted two versions of that question, and so it changed in the two iterations that you saw. But clear cell papillary RCC is one of the new 2016 WHO categories that is generally indolent. And the one to remember is HLRCC is very aggressive. So HLRCC aggressive, clear cell papillary indolent. And clear cell papillary, the name is confusing because it's got papillary in there, it's got the words clear cell, but when you see all three of those words together, clear cell papillary, that's the indolent one.
So Dr. Desai, thoughts on this one?
Yeah, so this patient has stage 1 RCC. The primary tumor is 7 centimeters, margins are negative, no lymph node involvement. So it's really important to select patients who really benefit from adjuvant therapy. Though the tumor size is 7 centimeters, it's still stage 1 RCC, and adjuvant therapy is not recommended for patients with stage 1 and 2 kidney cancer. It's recommended for patients with stage 3 and high risk disease. Great. So the only approved FDA treatment in the adjuvant setting in RCC is sunitinib. And again, this was based on the STRAC trial, which showed an improvement in disease-free survival of 6.8 years in the sunitinib arm versus 5.6 years in the placebo arm. And it's important to remember that this is based on improvement in disease-free survival and not overall survival.
So Dr. Desai, this is a kind of interesting because it's a category 3 recommendation by the NCC, and as you point out as well. How often are you using this in practice, and is there a sort of a subset of patients that you use it, or is it sort of default for all of these patients? What is your typical practice? And feel other panel members feel free to chime in as well on this one.
I'm sorry, that's a typo. That should be a category 2B recommendation, but that's that's a very important question. So though it is recommended or it's cleared by the FDA, we still don't commonly use it in clinical practice just because sunitinib is associated with a lot of toxicity and there's no improvement in overall survival, we still prefer enrollment in clinical trials if available for clear cell RCC patients.
Dr. Fan, Dr. Gulati, or Dr. Choueiri, do you have any comments on that in terms of your practice?
I completely agree. I don't generally prescribe it, no overall survival advantage, because there is a progression-free survival for the highly motivated young patient that I think could tolerate it, that says to, and I go over, there's no overall survival advantage, but they say to me, you know what, just not having this disease for an extra year is meaningful to me, then we'll try it. But I don't push too hard to stay on it.
Sorry, hi everyone. Good. No, I agree. I think I have not prescribed it ever. I think I have some reservation despite the FDA approval, which I'm not sure I would have done that. Not only the disease, it's a disease-free survival advantage, but also there are many trials that were cited by Dr. Desai in a very elegant manner that looked at subgroup analysis of higher versus lower dose. We did a subgroup analysis with Dr. Haas of patients that stayed on the higher dose for a long time and had higher risk. We didn't find anything. The OS hazard ratio approaches 1. So in my practice, if someone, not just highly motivated and young and understand what they're on, and you repeat, the trial, and they're coming already on sunitinib, I leave them on. That's the only situation. We have to ask ourselves why other TKI that are not inferior, some of them, to sunitinib in the metastatic setting, showed completely negative result. The good thing is we have 2 adjuvant trials, one with atezolizumab, one with pembrolizumab, that finished actually accrual. And we hope that these gonna come to fruition because these drugs are probably better tolerated overall. And the question is, would they result into a benefit? And the studies are quite large, both of them. And I think hopefully this will cater into a new era. The other thing I want to mention is, despite that, the adjuvant setting is a bit of a tough nut to crack, simply because you're gonna always, to some extent, overtreat. Surgery alone can cure even some of the highest risk patients, T4, grade 4. They could be cured, a small percentage by surgery alone. You do not have in renal cell cancer the PSA or other markers of microscopic disease, but circulating tumor cells are coming. They're coming strong. We've seen an analysis of IMvigor 010 presented by Dr. Powles in bladder cancer, and we are getting there. Renal cell cancer gonna be tougher simply because it is the tumor that shed very little DNA, probably the least after brain tumors. So it's going to be tougher to identify those patients, but technology does advance and it's going to be there. And hopefully these are the patients we're going to target with adjuvant treatment.
Thank you, Dr. Choueiri. That was very insightful. So we have a couple of questions in the chat, and one is for, I guess both are for Dr. Fan. So the first one is, what is the percentage of patients with a VHL mutation or methylation who eventually get RCC? Do you have any number for us, Dr. Fan, in terms of?
Oh, I guess you're asking for the breakdown. So I said that 3p minus, so loss of 3p is a kind of a universal event. And then if you take in total, 95% of patients or more will have 3p minus plus or minus a mutation of or methylation that gets rid of VHL. But I don't know the exact numbers of the breakdowns.
Sure. The second question is more so also for you. It says, can you envision a day when all kidney cancer patients will get reflex, somatic, and germline testing? I mean, if we don't take care of the reimbursement issues, do you see that we should be doing that, or that the future is that we'll be doing reflex, somatic, and germline testing for all of these patients.
I guess it's all in the number needed to treat. You know, if the germline is only a 3 to 5% positivity in all comers, I think it does make sense to be thoughtful about which population you're ordering them for. Ideally, a lot of information is better. And so, you know, I'm always an advocate in the academic setting of getting as much data as we can. We're actually finding, though, that maybe the targeted panel testing is not adequate because a lot of the mutations that happen in kidney cancer are not in the targeted mutations. They're actually in areas that aren't coding regions. So I think as our methodology gets better and the testing gets cheaper and we can do the right test that's appropriate for RCC, it might make sense. But as of right now, I think we can still be strategic.
Gotcha. Another question here is, would you treat patients with a VHL mutation the same way as your typical sporadic RCC, or would there be any difference in terms of treatments? Anybody from the panel could answer this.
I think Tony's going to talk about this later, aren't you? You're muted.
Maybe. I think here, I mean, it's good to say, I am not, you know, most of the vast majority of my work now is in translational research, but I have to say I'm not a big fan of genomics for clinical application in renal cells, simply because in clinic, I almost never act on it. So I usually do things I can act on. So, but I think the germline, the genetic syndrome in RCC are very, very reasonable. And the thing is, this movement is bigger than us. So you're gonna have at some point the genomic data there, like you have a complete blood count, whether they're useful or not, whether you have enough education and training to act on them or not. And most of the folks, you know, don't have that. So, you know, if you have a RAS mutation, which are uncommon, what are you going to do about that? That's not the same story as what you're seeing in lung cancer and colorectal cancer. So we haven't, you know, found that much in renal cell cancer, like lung cancer and other. Now, the thing is, the question about the VHL syndrome, I think if you have a VHL syndrome, a germline mutation versus non-germline mutation, the behavior is the tumor is different. And most of the VHL syndrome still have tumors in their kidney, and they have other, you know, manifestations. And these patients, you know, have a more indolent course, although some of them have metastatic disease. So you have to come up with a therapy that does not have significant toxicity overall to spare them surgeries, partial nephrectomy, and others. And remember also the tumors that they develop outside the kidney, the retinoblastomas and hemangioblastomas or others are totally different. They're not cancers in a way that clear cell RCCs are. So to that extent, there has been a several single arm trial, one with VEGF tyrosine kinase inhibitor that showed significant activity, pazopanib, for example, but also now more recently, the group at the NCI and MD Anderson and Harvard presented data with a novel compound, not yet FDA approved, which is a HIF2 inhibitor. HIF2 is a transcription factor, and it's been extremely hard to target, but you know, a lot of efforts and some elegant crystallographic work at UT Southwestern. And the whole biology is fascinating to a degree that the Nobel Prize in 2019 was awarded to 3 individuals, you know, to that extent. And the medical oncologist on the panel, Dr. Kalin, my close mentor and collaborator and friend, got it from the medical oncology angle, talking about HIF2 in renal cell carcinoma as part of the bigger picture of hypoxia and oxygen sensing. And this drug, you know, MK6482 belzutifan, showed, you know, very good responses. It's well tolerated, single arm study, and hopefully at some point it will become an option in kidney cancer, because TKI do have, you know, significant side effects, and they're taken continuously. So that's maybe this is a long answer to a short question. So I apologize. It's Sunday.